So my name is Jana Kenny and I am a final year clinical genetics registrar and I'm also a research fellow at the UCL Great Ormond Street Institute of Child Health, and I just submitted my PhD on Friday and I've been studying whole genome sequences generally with pharmacogenomics in particular. Now, you will be pleased to hear that I'm not here to either slavishly read through the guidelines with you, nor am I here to teach you any clinical pharmacology. But what I do want to do is tell you about a train that is coming down the tracks at my specialty and at your specialty that we are going to be dealing with, and how we might go about doing that and the sort of pitfalls that we might encounter. So you've all seen the various definitions of precision medicine that hover around, but this is one that comes up again and again, giving the right drug at the right dose to the right patient at the right time. And that's what we're all trying to do. Now these are very old figures. These are from 2001, but they're looking at how efficient various treatments are. And actually, while I couldn't find a more up-to-date slide for this, we're still not great. A lot of the drugs that we give to patients may not be effective for everyone, and pharmacogenomics is one of the ways we think about why that might be. The other reason we might want to think about the drugs that we're prescribing is the cost. So these are NHS figures from 2010 to 2016-17, and primary care is in yellow and secondary care is in orangey red. And what you can see is that in terms of hospital-based prescribing, the cost has almost doubled in the last 6-7 years, whereas primary care has stayed reasonably static. And this may be both, maybe due to things like an aging population and the increased cost of new drugs. So, pharmacogenomics. What we do at the moment is a pretty much one-size-fits-all drug approach. That's certainly the case for most specialties, possibly not for you guys who are maybe better at this than most, but a lot of the time it's look up the BNF, prescribe the drug. And there are estimates that up to 10% of all hospital admissions are caused by adverse drug reactions, and it's an expensive business. So the UK figures are from 2004, Professor Pierre Mohammed's group, and they estimated that at that point we were paying £466 million a year. It's only gone up since then because bed days are more expensive than they used to be. It's a problem in paediatric patients, who are the group that I tend to deal with. They are more likely to have a life-threatening adverse drug reaction if they're going to have one. And paediatric ITU beds are incredibly expensive. So why might this be? Pharmacogenomics is one of the reasons. And it's something that's being talked about quite a lot at the moment in various fora, and there's an awful lot of publications coming out, but I'm not sure that we always know as much as we think we know. So again, this is a slide that you've probably seen. We want people to be in the happy green group, which are the ones who are benefiting from the drug and not getting the side effects. We're not that keen on the people who are benefiting from the drug in blue but getting additional side effects. It depends on the condition you're treating and how bad the side effects are. The drug's not beneficial, but they don't have side effects, so these guys are no worse off than they were before you started. But these unhappy people up in red are neither benefiting from the drug, nor are they feeling okay because you've given them side effects from your treatment. So we would ideally like to get everyone into the green group from the beginning, rather than using trial and error and changing people when they develop side effects. So I thought we'd put up a little bit of a pharmacology slide just to keep everybody happy. This is to remind me that it is not as simple as one gene, one drug. It's a lot of genes metabolizing a single drug, and also a lot of drugs being metabolized by a single gene. So that's something to always hold in the back of your mind, that it isn't just a straightforward thing, even if the guidelines make it look like it might be. And what we know is that genetic variants can alter the function of various metabolic enzymes. So this was a study done in 2016, and they looked at only 5 of the well-known pharmacogenes. So they looked at 3 of the cytochrome P450 genes, and they looked at a couple of other things as well. Looked at around 1,000 people, and only 1% of people had no actionable variants in any of those genes. So the other 99% of people had variants that would potentially lead to an alteration in prescribing in one of the pharmacogenes, and the majority of people had 2, 3, or 4. So this was considered to be reasonable evidence for how we might want to have a preemptive pharmacogenomics testing service. So just a bit of background. So what we try and do with pharmacogenomics is we try and divide people into these classes of metabolizer. So For example, just using CYP2D6 as an example, we divide people into ultra-rapid metabolizers, normal metabolizers, which used to be called extensive metabolizers, but we're moving away from that because it's a bit of a confusing term, intermediate metabolizers, and poor metabolizers. So we look at the genetic variants and we try and put people in one of these classes, which allows us to prescribe appropriately. Now, as a very general rule, ultra-rapid metabolizers will clear drugs very quickly, and they are less likely to benefit from them because they never get the levels high enough to benefit from the drug. Whereas the poor metabolizers, the levels build up because they can't clear the drug appropriately, and they're the group that get side effects. That's not an absolute hard and fast rule, because when you have a prodrug that's metabolized to an active drug, the opposite thing happens. So, for example, with codeine, ultra-rapid metabolizers convert codeine to morphine and are at risk of overdoses, whereas poor metabolizers, the codeine just sits there, doesn't get converted to morphine, and they don't get any benefit from their codeine that's been prescribed. So how do we do that? So this is the genetics bit. Does everybody know what a SNP is, a single nucleotide polymorphism? Excellent. So we essentially look at SNPs, and we look to see whether people have the reference sequence of particular SNPs or if they have a variant. And putting together these SNPs lets us divide people into the various classes. Now, we all have 2 copies of every gene, one from mum, one from dad. Each copy gives us a haplotype. So you will have one copy that has a particular haplotype. These are those star numbers down the side. And the other copy will have a particular haplotype. And the combination of those 2 haplotypes gives you your diplotype. And the diplotype will be associated with one of those metabolizer phenotypes. So, for example, in this case, if you look here, if an individual has a G at this second SNP and an A at the 4th and a T at the 5th, they will have the star 4 haplotype. If they have CG, GA, CT, then they'll be a star 1, star 4. And that's when you've got people in, when you know the diplotype, then you can assign the metabolizer classes. It's not quite as simple as that, and we'll come back to why it might not be later on. But once you've done that, once you've assigned the diplotypes, you go looking for the guidelines. And there are various people making guidelines at the moment. So this is one of the big ones, the CPIC, the Clinical Pharmacogenetics Implementation Consortium. They produce a lot of guidelines, and they're excellent. This, I'm not going to try and pronounce it in Dutch, but the Dutch Pharmacogenomics group works under the umbrella of the Royal Dutch College of Pharmacologists, and they also produce guidelines. The Canadian Pharmacogenomics Network for Drug Safety produces a lot of pediatric-centric guidelines, which is unusual because nobody else does, but also other guidelines, particularly around opiates. And there are other ones as well. So Royal College of, the College of Rheumatologists has some particular guidelines for their drugs. There are lots and lots, as well as things like the European Medicines Agency and the Food and Drugs Administration. So this is where you find them all. So PharmGKB is the website of choice for going to look up your guidelines. And when you go, this is what it looks like. So I took this screenshot a couple of months back. We're up to 101. Obviously, just as I finished writing my thesis, they introduced a new dosing guidelines. So we're up to 101 dosing guidelines now. And you just type in your gene or your drug and click on the dosing guidelines, and it will tell you what to do. So if you click onto CYP2D6, you can see this is the top of the page. So we start with the CPIC guidelines, and then as you go down, you'll see the other guidelines. And the thing I want you to notice here is that there are lots of guidelines that are just CYP2D6 and some that are a combination of CYP2D6 and CYP2C19. There are a limited number of combined guidelines, and combined guidelines are really important, and we're going to talk about why that is in just a minute. But there are drugs with separate guidelines for CYP2D6 and CYP2C19 where combined guidelines haven't yet been formulated, and that's problematic. So clicking through again, this is where we have our examples of our diplotypes. You can see in the 4th column there. So if you're a star 1, star 1, star 1, star 2, you will be an extensive or normal metabolizer, and you just have the normal standard age or weight specific dosing. Whereas if you're a poor metabolizer, for example, if you're star 4, you need to avoid codeine because it's not a useful drug for you. So they're very clear to follow once you know what your diplotype is. However, What we know is that CYP2D6 has more than 100 different haplotypes, and therefore if you think of all the possible combinations of diplotypes that you can get, you can see that these guidelines cover a limited number. You can extrapolate a bit if you know that somebody has 2 poor metabolizer haplotypes. You can assume that their diplotype will be poor metabolizer, but you don't have this kind of evidence-based guideline to follow, which might be fine for you guys, but may not be fine for your GP, who is maybe going to be expected to prescribe on this basis. So I know you can't read this. This is just the traffic light system that most commercial pharmacogenomics testing uses. Red for drugs to avoid, orange or yellow for drugs to be used with caution, so that might mean a change in dose or a change in monitoring, and green to be used as directed. So just to zoom in here, this illustrates a point. This individual, while there are combined guidelines for tricyclic antidepressants, you can see that they're being told to avoid tricyclics for the opposite reasons here. So CYP2C19 ultra-rapid metabolizers should avoid tricyclic antidepressants. CYP2D6 poor metabolizers should also avoid tricyclic antidepressants for exactly the opposite reason. So we really have no idea what the clinical effect for this patient is going to be. You end up avoiding tricyclic antidepressants because you just think it's not worth risking it, but actually maybe they'd be fine on a standard dose. So combined guidelines help you with that, in that it tells you what to do, like don't prescribe this drug. But it's a pretty blunt instrument if you think about it. It's just, we're not too sure what's going to happen here, so let's not do it. So this is the bit that we really need to think about. If we're implementing this as a service, how are we going to do it, and what do we need to think about? So I'm not going to go through this. You know why it's a good thing. It's good for doctors, for patients, for the NHS in terms of health economics and giving people the right drug and them getting better. It's probably good for pharmaceutical companies because if they can dose their drugs appropriately, it is probably going to be cheaper and quicker and easier to get drugs through the trial phase if you're giving people appropriate doses and avoiding the people who may have reactions. But we're going to talk a bit more about why that might not be good. So at the moment in the NHS, we fund, this probably isn't displaying very well, but TPMT testing. Carbamazepine, if you're starting carbamazepine and you are Thai or Han Chinese, you're supposed to have a pharmacogenomic test. Did you know that? Yeah, some of you did, I didn't. Abacavir, you're supposed to have a test. And this is an interesting one. Eliglustat is for Gaucher disease, and it is not licensed and not recommended by NICE for CYP2D6 ultra-rapid metabolizers. So if you have Gaucher disease, and you have the appropriate genetic test and you are found to be an ultra-rapid metabolizer, you don't get the drug. And there isn't really an alternative. So that's one of the issues with this that we need to think about. Who has sent patients to the 100,000 Genomes Project? Couple, 4, 5. So this is my life at the moment. I am getting results back from the 100,000 Genomes Project who have now sequenced, they're very proud of themselves, 100,000 genomes. Not all patients. We have some trios, so affected children with their parents, and we have cancer patients plus their cancer genome. But the results are coming back for the diagnostics. Now, 100,000 genomes have great ambitions to extend this to pharmacogenomics, and they have blithely announced that this is something that they are going to be doing going forward. They thought that the specialty of choice for returning all of these results to was clinical genetics because, we were getting most of the results anyway. Clinical genetics are not keen. We don't think that this is something we're particularly good at. So they're kind of casting around for other specialties that might be well placed to deal with this. And I know if I were deciding the policy, I might think that clinical pharmacologists would be exactly the people to take this on. So this may very well be coming your way. And there are lots of companies offering testing at the moment. So most of these are in the States, but Congenica is in the UK. It's based out of the Sanger Centre, and they are about to start offering a panel-based test to UK clinicians. And we're going to talk about how these companies test, but basically it's happening. It's happening a lot in the US, and it is going to happen here, either through 100 genomes or otherwise. So how do we test? This is nice and simple. If we're starting someone on one of those drugs, like you're starting someone on mercaptopurine, you do a TPMT enzyme or gene test. You get one result, and you decide what dose to start your patient on. Nice and simple. I'm not going to go through that. So the pros of that are that it's really cheap. An enzyme test is sub £100. It's relevant because you're about to start the drug, so it makes perfect sense to do it. It's relatively quick, and it's very easy to interpret the results. You get your metabolizer phenotype and you prescribe the appropriate dose. The bad things are that it's pretty limited. It doesn't tell you anything about anything else. And it's rare that it's done preemptively. Unless you're a very organized clinician who sees which way your patient's going and sets up the test in advance, you then have to do the test at the point that you'd really like to initiate prescribing. So, panel testing is really what's happening mostly in terms of the commercial field. So a panel-based test is really a SNP array. So there's a whole load of single nucleotide polymorphisms on a little chip, and you sequence those and you pull out the haplotypes and diplotypes for your patient. And this is, you can do SNP arrays with millions of SNPs, but the pharmacogenomics ones are usually between 150 and say 500 SNPs. And you need to decide when it's appropriate to test. So this is just an example of the test that Congenica runs, and basically you are looking to see, this is a single SNP for a single pharmacogene. You might have multiple SNPs affecting a single pharmacogene, but you see whether people are reference sequenced down there in red, let's say for example CC, or if they're in this heterozygote green group where they're CG, or they're up here in the homozygote non-reference group, in which case they're GG. So this is the Congenica result. They work with a company called Translational Software. This is my consultant got hers done quite bravely, and she came in clutching this piece of paper last week, and they again use this traffic light system, green, yellow, red. This is page 1 of 6. So that's quite a lot of information to be handing back to a GP or a patient. She was particularly interested because her family has an extensive history of cardiovascular disease and strokes, and quite a number of people have had a stroke and a second stroke. So now she's exercised about what she's going to do if she has a stroke and how she's going to persuade people to change her prescribing based on this result. And I don't know if she is, to be honest, if she attends her local A&E with a stroke. And that's one of the problems. We haven't really thought about how we might implement this. So the pros of panel-based testing are that it's relatively cheap. So Congenica, I think, are going to offer their panel for about £650, which in genetic terms is reasonably good value. Relatively easy to interpret because you know what's on there before you start. No nasty surprises. The cons are that you can't update it. The panel is the panel, the SNPs are the SNPs, and you can't go back and change them. So you run the test, and that is the information you have. If a new pharmacogene gets published tomorrow, if they find that there's some super relevant SNP that you need to determine the CYP2D6 diplotype, it's not there, and you can't add it on. Again, because you're limited in the number of SNPs, and the SNPs are the SNPs, it's not good at covering all ethnicities. So it tends to be biased towards the population of whatever country the test is in. And traditionally, a lot of this research was done on people of white ethnic backgrounds, so it may not be relevant to everyone. You can't interpret copy number variants, which is hugely important for CYP2D6. You have to do an additional test for that. So this is probably where we're going, and this is certainly what 100,000 genomes is going to be doing. They're going to be using whole genome sequence to pull out the pharmacogenomic data. So, quick reminder, whole genome sequence is sequencing everything, coding and non-coding. And you get all of this information, millions and millions and millions of SNPs back, and you interpret it. So, you're going to have to do that computationally for all but a very small number of pharmacogenes. I did it manually. I don't recommend it. That's how I got a whole PhD out of doing this. But there are going to be computational methods for doing this, and actually a big series was published recently where they have done this computationally. There are some pitfalls with computational things. I use some computational stuff to pull out some of my data, and when you go back and you check manually, it's not always right. So the pros are that you cover all of the genes and all of the SNPs. So if a patient who is an Inuit comes into your clinic and you know what SNPs are appropriate for them, you can look them up. If they publish a new gene tomorrow, you already have that data. You can go back and check. You can look at copy number variants. We're getting better at that with long-read whole genome sequencing. So that's something that we're going to be able to do absolutely routinely in whole genome sequencing very soon. At the moment, we need computational methods to help us pull out that data. And you can go back and update it as required whenever there's a change. It's expensive. This is not something you are going to do just as a pharmacogenomics test. the cheapest you can get a whole genome sequence for at the moment, if you pull in all the favors and you do a big bulk order, you can probably get them down to about $1,000 US. But you're not going to fork out $1,000 US for a whole genome sequence for non-diagnostic reasons at the moment. However, we're mainstreaming genetic testing from maybe January, maybe March, and everybody who sees patients who might have a genetic diagnosis is going to be able to request a whole genome sequence in certain circumstances. And at some point, that is going to come back complete with bonus pharmacogenomics results. Variants of unknown significance are a huge problem. They are variants that we see but we can't interpret. We know that there are more than 100 haplotypes for CYP2D6. There are hundreds of SNPs that make up those haplotypes. What if you see a SNP alongside a SNP that you know is clinically important and it's right beside it? Does that make a difference? Does it not? We don't know. Secondary or additional findings. You are sequencing the BRCA genes, you are sequencing the CF gene, you are sequencing loads of weird and wonderful metabolic genes. You sequence enough patients, you will find nasty secondary findings that you really wish you didn't know about. And you need a plan for these before you start. You need to be quite clear about what you're going to feed back and how. So 100,000 genomes have said that they will feed back cancer susceptibility results, so BRCA variants and Lynch syndrome variants. Some will be fed back to children if children can benefit from screening or intervention in childhood. Others will be fed back at adulthood. I think by me, probably, but they haven't started coming back yet. So that's a whole other thing that's going to be a problem. It's difficult to interpret without serious computational support. And on the con side as well as the pro side is that you can update it. And we're going to talk in a minute about when you may or may not want to do that. So when you do the testing, depends on the test type. Pretty easy with a one gene or enzyme test. You just test when you're starting the treatment. The panel tests, in the US, the approach seems to be that you test at the time of a major illness or going to some really fancy hospital that offers this as the kind of benefit of going to the Mayo Clinic. So a lot of the panels that are marketed in the US are marketed as cardiovascular panels, psychiatric panels, cancer panels. So you get your cancer diagnosis, you have your cancer panel. They're very secretive about what exactly they're testing. It is really difficult to find out what genes or SNPs they've looked at. So it's very difficult to tell how relevant that test is to you. Or you could test at any point but preemptively. And this is where whole genome sequencing, this is where you kind of feel that fits. You could do it at birth. We could all have our whole genome sequenced and then we would have that information there as and when it was needed. Or you could go for the at times of increasing need. So maybe when, at a point where patients begin to develop polypharmacy, you could decide that was a good time to intervene. But actually at the moment it's going to be opportunistic. It's when you have your whole genome sequenced for another reason. So which genes do we test? Again, it depends on the approach. The panels will have decided that for you. And there may be a gene that you're really interested in that's just not there. But if you do your whole genome sequencing, you've got it all and more. But I think we need to think about the guidelines. A lot of the pharmacogenomics information that's out there, there aren't really robust prescribing guidelines. There are recommendations, there are small studies. But I, for one, and maybe you guys are braver than me, but I'm not changing my prescribing based on some small study in 5 people of an ethnicity other than that of my patients. So personally, without robust, peer-reviewed, published prescribing guidelines, I'm not doing anything other than the standard. So I think we need to think about what guidelines are available when we're reporting stuff back to patients. The guidelines are getting better. There's new ones being added all the time. This is going to improve. But at the moment, there's a relatively limited subset of genes and drugs that we can do this for. So I think there are pros and cons of testing lots of genes. But again, we'll pop back to that at the end if you have time. But this is, I think, one of the huge take-home messages of genomics generally. You can test as many genes as you like. You don't need to look at all of them. And you can look at as many genes as you like. You don't need to report back all of them. So we apply panels to our whole genome sequencing. If a child pitches up with epilepsy, we do an epilepsy panel, and we hopefully find something in there. If not, we can choose to extend it to a more general developmental delay panel or a microcephaly panel or whatever else. But we try and restrict what we look at because we don't really want to find a BRCA variant in a 2-year-old who presents with epilepsy. So you don't have to look at everything and you don't have to report everything. at the moment. So it is more complicated than it seems, partly because of the choice of guidelines and the lack of guidelines. So there are guidelines for lots of drugs in a class, but not all drugs in a class, which is problematic because it tells you firmly not to prescribe this particular drug, but it doesn't tell you maybe what else to prescribe instead. The guidelines, which ones do you pick? You might argue that the Dutch guidelines are in the EU. They are in keeping with the recommendations of the EMA, which we may or may not be going along with come March. The CPIC guidelines are a multinational consortium. They often have UK people on the expert panel. But at the moment, there isn't a clear national strategy for which guidelines we might choose. And the guidelines don't always say the same thing. Lots of genes that we know have probably very good evidence, but nobody's gotten around to making the guidelines yet. And lots of drugs that we know, again, we know that they're metabolized by these genes, but nobody's gotten around to making a guideline, maybe because the evidence isn't there yet. The guidelines are not perfect. They contradict each other. So, for example, in the case of CYP2C9, the STAR8 haplotype is called a increased metabolizer phenotype by the CPIC and a reduced metabolizer phenotype by the DPWG. Now that's simply an issue of timing because the CPIC guidelines were revised more recently and they picked up a change in the evidence that has made us think differently about this STAR8 haplotype. But, that's a whole set of guidelines that's quite a rare haplotype. I didn't come across anyone in my study with that, but the fact is things have changed. There are very, very limited pediatric guidelines. A lot of the guidelines helpfully say these may apply to children, but they don't give any recommendations. And medical legally, I don't know where that leaves us, those of us who prescribe to children mainly. They frequently don't recommend an alternative. They say don't give this drug, but they don't say what to give instead. Sometimes they do, and that's really helpful. But if they don't, where does that leave you? As I said, there are some guidelines that look at multiple genes simultaneously, only ever 2. Nobody's done any 3 gene guidelines apart from, there's a couple that all metabolize the same few drugs, which are considered together. But that's something that I think will improve, but it's not perfect at the moment. And there are drugs which have guidelines for one gene and guidelines for another gene, and it is not unlikely that if you sequence enough patients, you will get completely opposite recommendations for them, and that leaves you worse off than before you did the test. So you guys know more about this than me. I was learning a lot there in the last talk, but it's not just relevant to pharmacogenomics, but I do think that the danger is that if we are prescribing in a very guideline-driven way, we may forget to think about the things that we used to consider on a kind of a clinical basis. So, for example, fluoxetine is a potent inhibitor of CYP2D6, and it changes your normal metabolizer to a poor metabolizer, essentially, in terms of phenotype. But if you are slavishly following your pharmacogenomic prescribing guidelines, you may not think of that, whereas actually you might have thought of it if you were just looking at a drug chart and deciding what to add at a normal dose. So yeah, I think that could be a problem. Rare haplotypes and variants. So some of what we know is wrong. I was really upset when I was doing my research about this SNP that kept cropping up at a way higher frequency than I was expecting this particular haplotype. It was the STAR5 haplotype of DPYD, and I couldn't understand why I was finding it so many times, and I looked at my sequencing data and I did all sorts of things. And then eventually, which I should have done in the beginning, I went and I looked up EXAC, which is the exome population database. And actually, the frequency of the variant in EXAC is exactly the frequency at which I was seeing it in my study population, which is about 3 times higher than the supposed frequency of this STAR5 haplotype in patients. So it's not the only SNP associated with STAR5, and it may be that it's in linkage disequilibrium with it. It may be that it was seen at a particularly high rate in whatever population was studied in the data that was pulled out of. But the fact is, either the STAR5 haplotype is way more common than we think, or that SNP is probably not part of the STAR5 haplotype. And that's something that we're going to learn more and more about as our whole genome data gets better. some of the time there's very little actual clinical confirmation in terms of measuring of enzyme function for these haplotypes. It can be quite theoretical, and some of it, particularly in minority ethnic populations, is based on quite small sample sizes. So I don't know that we can always be completely confident, particularly when you're extrapolating. You're saying, okay, this is published as a poor metabolizer haplotype, so I'm going to follow the poor metabolizer prescribing guidelines. I don't think the evidence is always robust. As I said, whole genome sequencing is showing up a lot of errors, because previously we just sequenced what we knew about. And when we found it, then we said, oh, there it is. But now when we're sequencing people completely agnostically, we are getting much better ideas of the numbers of people with variants. So I do think this is something that's going to improve. However, if you change prescribing wrongly, for whatever reason, you are then causing a harm that might not have happened. If you had just given the standard dose, maybe they would have had side effects, but you were doing something that a reasonable medical practitioner could have done. You do a test and you tell them, well, actually, you're an ultra-rapid metabolizer, so I'm going to whack up your dose to double what it would have been. You have done an intervention that has then potentially caused them harm. So I do think we have to be careful with this. And I think a lot of the commercial tests are quite gung-ho about this, and we have to be a bit careful if we're bringing something into the NHS that we're not just doing what the private sector does. Ethnicity issues I have touched upon, but I think this is really important. We all know that warfarin, people react differently to warfarin dose, and actually if you look at the pharmacogenomic guidelines for warfarin, they recommend the testing of specific SNPs in other ethnicities. So, for example, for people of African origin, you test a SNP that you don't need to look at in people of white European origin. But really, it's only warfarin that we've got that for. Probably this should be the case for most of the pharmacogenomics prescribing guidelines, but we really aren't there yet in terms of the guidelines. So we don't know that the prescribing we're doing based on these guidelines is absolutely fit for purpose, and there really isn't the data at the moment because it's being done in such a patchy fashion. So certain hospitals in the US, really not much at all in the NHS. And the danger of rolling out some kind of whole population, large scale, let's just do this because we have the data intervention is tricky, because I don't think we necessarily have all the evidence. We'll certainly get it if we do it on a population basis, because we'll find out where we're running into problems, but I don't know if that's maybe the ideal way. On the other hand, at some point you do have to take a bit of a plunge, because you're not going to get the evidence without trying it. So the guidelines aren't fixed. As I said, this was a real trial to me during my research, because they kept changing them. Not only did they put in new drugs and new genes, but they also took away guidelines. So DPYD and Tegafur, that's gone from PharmGKB now. And they have reclassified various haplotypes based on the new evidence. And I think this brings us to the question, what exactly are our obligations in terms of that? Do we have a duty to update? I don't think we know, but certainly our feeling in genetics is that we ought to be looking back over diagnostic whole genome sequences to reclassify variants of unknown significance in the future. At the moment, the flood of results inwards means that we're barely looking at the results we're getting right now, never mind going back over the ones we got 2 years ago. But I suspect that we probably do have a duty to go back. Now, there was a case going through the courts in the US that we were watching with interest. There was a child who had a seizure syndrome, who was found to have a variant of unknown significance in an epilepsy gene. It was later reclassified as a pathogenic variant, but the lab never updated it. The child died, and the parents sued for wrongful death. Now, it didn't go all the way to the Supreme Court because of a jurisdiction issue. In the US, you used to be able to sue a company in whatever state you wanted, and it was pretty much always California, because that's where the big payouts were. But recently it's been decided that actually there has to be a connection to the state. So the company has to be based in the state, or the patient has to be based in the state. So that case was thrown out on jurisdiction issues, and I'm not sure they would have won on wrongful death anyway, because it's unlikely that knowing the diagnosis would have materially changed the outcome. But at some point, it is going to happen, and I think there will be a duty to update, because we are sitting on this data. So I think there's going to be, and I think that will probably be the case for pharmacogenomics as well. But who has it? Is it the company that does the testing? Is it the doctor who requests the testing? Is it the unfortunate GP that the patient hands their report to 10 years down the line and says, can't have clopidogrel me, I need something else? Who's got that duty? We don't know. But probably it's not going to be the company with their 25-page disclaimer done by their lawyers that says, this is the testing at the point of testing, and we have no duty to update and we won't do it. But if you prescribe something based on a guideline that no longer exists, you may run into problems. And we don't know the extent. We don't know whether you're going to have to kind of chase up patients and say, actually, the information we gave you may have changed, or if it'll be just at the point of prescribing, or what. What if they've been on the drug already? Do you then have to go back and say, I'm not sure that dose we gave you is the ideal? We're going to, so we just don't know where the duty lies, and we don't know who the disclaimers will cover. But probably not us, probably not the prescribers. The economics are more complicated than you think, because it's not just test versus cost of side effects. It's also all the kind of possibilities of the side effects, like long-term disability, the fact that the patient doesn't comply with treatment because they're having horrific side effects, the fact that you are trying third and fourth line medications, but also the fact that if you test enough people and you say, okay, well, everybody who's a poor metabolizer of such and such a gene is going to have this alternative drug, the alternative drug is always more expensive because we always give the cheapest one. So you are potentially looking at putting huge numbers of people on more expensive drugs without necessarily knowing that that's necessary, because not everybody who's a poor metabolizer of clopidogrel will definitely have a second stroke. We know that they don't. But if you're putting everyone who's a poor metabolizer on a more expensive alternative, that's got to be taken into the economics. And you will be unsurprised to learn that if the test is extremely cheap, or if the benefit of doing the test is extremely big, we can show that it's cost effective. But for everything in the middle, it's unclear. This is another thing. We're going to be expecting people to act on these recommendations. It is okay if you are in a secondary or tertiary centre where you kind of come together and you have some prescribing guidelines and you're supported in that. But what about the GP in their surgery who just wants to give the SSRI? It is tricky. So again, I think we need some kind of sensible national strategy. I think we all need to be following the same guidelines. I think it shouldn't be that if your drug is prescribed in Devon, you're going with one thing, but on the other hand, if you move up to Scotland, you're going to be being prescribed stuff on completely different guidelines. We need a strategy. There was a while where the 100,000 Genomes team thought they would develop their own prescribing guidelines, but I gather that's been quietly shelved. But I'm unclear at the moment which guidelines they think they should use, or whether they're just going to produce the diplotypes and send them out and let us do the deciding. I'm not sure. They may know, but I don't know. I don't know if anybody else has heard. Education is going to be hugely important. Medical students are beginning to learn about this, but I mean, if you guys aren't super confident, I know we're not super confident about this, then it probably means that almost nobody is. And we have to get over that somehow if we are going to start sending these results out to neurologists and cardiologists and pediatricians. And at the moment in the US, I think there is a real problem with two-tier care. If you are having your cancer treatment at the Mayo Clinic, you have your whole genome sequenced, you have your tumour's whole genome sequenced, and you have a lovely pharmacogenomic test to best inform your cancer care. If your insurance doesn't rise to the Mayo Clinic, you're having none of that. You're having standard treatment. And that's not unusual in the US, but at the moment in the NHS, while things aren't perfect, it is much fairer than that. And it would be a real shame to see this sort of adopted by tertiary centres and not by other hospitals. So if you go to Great Ormond Street for your cancer treatment, you are getting different care to if you go to somewhere else. And we're talking about fairly standard care here rather than fancy cancer treatments. But if your basic care should be the same whichever hospital you're treated in. And I wouldn't want it to be something that was adopted by some centres only. And I think that's a worry. Many people, don't know why, but many people are scared of genetics. I go to talk to neurologists and cardiologists about the fact they're going to be getting their own whole genome sequencing results back from probably March. They're absolutely terrified. And they say, well, but you'll tell us what to tell them. And we say, well, not really. The results are going to go to you and you're supposed to feed them back to the patients. Nobody wants to do that at the moment. And this is the strategy. The NHS testing strategy is that everybody will be able to order whole genome sequencing for specific indications. So for example, with a neurologist, unless it's a clear case of Huntington's or there's an obvious single or panel test to do, if it's one of these mystery, probably genetics, but we really don't know and it doesn't fit neatly into a panel, they will be expected to request a whole genome sequence and they will get the results and they will be interpreting the variants of unknown significance. I think it's going to be tricky. Tests are fallible. This is something that I learned when I was doing my own testing. I validated my results with Congenica's panel, and sometimes my results were wrong. When I went back and I really looked at my whole genome sequence, I could see that I'd missed something because the coverage wasn't great or because the allele fraction wasn't quite 50%. Other times, it looked like the Congenica results were wrong because if you recall that picture with the clustered dots, lots of things lie between two clusters and you kind of go, oh, slightly nearer the bluer one, we'll call it a homozygote. But actually, if you go back and look at the whole genome sequencing in an area that's well covered and we know we're good at sequencing, it is absolutely a barn door heterozygote. But there may be a SNP, maybe 10 base pairs upstream, that's obviously affecting how that amplifies. So no testing is perfect. And at the moment, I don't think we know what the error rates are for these things. And as we've talked about, ethnicity makes things tricky. And out-of-date guidance makes things tricky. Now, sometimes it won't do any harm because actually you've missed the SNP for the star 53 haplotype of CYP2D6, but there's no prescribing guidance for that anyway, so it doesn't matter. However, sometimes it will, and potentially that's the one you're going to run into problems with. Variants of unknown significance, bane of my life. But whose problem are they? If the results go back to you guys or to the neurologist, they're not my problem anymore. I won't be the one chasing them up. So we need some kind of nationally agreed strategy for doing this. And again, we come back to this duty to review. Do we have it? When does it happen? How are we going to do it? And how are patients going to feel about being contacted 10 years later going, you remember we told you your whole genome sequencing was normal? Well, actually. Or remember those nice pharmacogenomics results we gave you? Well, actually. I think patients are going to be quite unhappy about that because it's a hard concept for us to understand. I think it's going to be even more difficult for people with no genetics background whatsoever. Secondary findings I've touched upon, but I cannot tell you what a headache this is going to be. It really is. So cystic fibrosis, CFTR, is on lots of pharmacogenomic panels because it is relevant to whether or not you prescribe ivacaftor. But if you find a variant, you have just done a carrier test for CF. We do not do that without a little sit-down chat and some nice written consent and a plan for feeding back those results. And I can almost guarantee you that if you ring someone up out of the blue with a CF carrier result, they will be pregnant. Absolutely, invariably. This happens to me at least weekly. You ring someone up with news like this, they are always pregnant. I don't know how it happens. But then, you've introduced this huge anxiety at 32 weeks of pregnancy or some really too late to even think about doing anything stage. So we have to be careful. I looked at G6PD in my research. G6PD is an X-linked gene. Men should only have one variant. So you should see a G or a C or a T or whatever, but you should only see one thing. If you see a C and a G at a particular position, you have just diagnosed that chap with Klinefelter syndrome, which is great. Are you going to tell him? Probably not. It's really tricky. But there are when you get onto whole genome sequences, there are millions of opportunities to do this. And you can do it really inadvertently. I didn't realize that this was a possibility till I went to this great talk and this American pharmacologist who is running a pediatric trial in St. Jude's told us about the time that she had done exactly this, which then made me really nervous every time I opened up somebody's whole genome to look at their G6PD results. Happily, I didn't diagnose anyone with Klinefelter, but I have no idea what I would have done if I did, because I didn't think about this before I started. So yeah, there's going to be loads of those. BRCA genes are going to go on these panels because they're going to affect how, whether or not you're going to respond well to PARP inhibitors. So there you go. There's your predictive BRCA carrier test. Long-QT genes are all going to go on there because, loads of drugs. It's important to avoid them if you have long-QT syndrome, right? But there you are. You've just done a test for sudden cardiac death. You now have a worried patient who is probably going to need some kind of implantable cardiac defibrillator. Not only that, you have his children, you have his siblings, you have his parents. It's tricky. So familial issues. Most specialties don't like dealing with this. We don't mind because we have nice familial notes. We have appointments that are set up to see multiple family members. I get loads of time to see a family. I can deal with as many cousins as you want to ask me about. But that doesn't work in a 10-minute clinic appointment where you thought you were talking to someone about their Parkinson's meds. Or their, and you incidentally find a long QT mutation, and they say, but what about my children? What about my brother? My sister is pregnant. The sister's always pregnant, I promise. So it's really, really tricky. How far do you go? Is it just their children? Is it their parents? Is it their siblings? Where do you draw the line? Do you just write a nice note to the clinical geneticist saying, please see this whole family and sort it out? You probably do at the moment, but if we're all doing this on a large scale, clinical genetics aren't going to be able to cope, barely coping as it is. So I think it's going to be tricky. And how do you disseminate that information? I am a master of the to whom it may concern. We have found something that you need to know about, but it's tricky. So I think long QT and mitochondrial mutations for aminoglycoside deafness are two that are going to come up very quickly. The legal duty for this may change because St George's Hospital is being sued for not disclosing a Huntington's result to family members. At the moment, we think we don't have a legal duty to disclose for the most part, if the patient doesn't want us to, but we might be about to be told by the Supreme Court that we do. So I read a paper recently that suggests you should be taking 8 to 9 hours to consent someone for whole genome sequencing. That's the appropriate amount of time to talk about the secondary findings. We probably spend maybe 2, and that's for a very limited set of secondary findings. Who's got 8 to 9 hours to consent a patient? It's ridiculous. It's never going to happen, but that is what people are saying to do it properly. And who explains the results? Either me or you, I would be willing to bet. Who keeps the data? And then other things, so equitable access we've talked about, acceptability, access to treatments. If you have a genetic test and it's found that you're not going to respond to interferon and you don't get prescribed interferon on that basis, there isn't really much else. So you've just done a huge disservice to your patient who might well have responded to the interferon if you hadn't done the test. And we've talked about eliglustat already. Commercial testing, you do not know what they're going to do with your data. If you read the small print, they say, these are the terms and conditions right now. They may change, and that is all they say. So you have no idea where your data is going to go. We do not have a nice unified NHS IT system, which I think is pretty essential, because otherwise who holds the results? Is it the GP? Is it the hospital? Is it the patient? We don't know. Who's going to pay for it? Will the patients understand? Where are we going to store this data? Who's going to update it? Who's going to fund the alternative drugs? But it's happening. So there's this PREPARE trial, which is an EU-wide trial that is ongoing at the moment. They have these clever little QR codes on cards that patients have, and theoretically you can update that from the back end to always have the most updated prescribing guidelines. Works brilliantly in the Netherlands because they have one prescribing system for all secondary, tertiary, primary care, and it's also in every pharmacy. So it's very easy in the Netherlands. Lots of small trials going on, usually for one gene or one medication. We're sort of talking at St George's about trying to set something up, but we haven't managed to get very far with it yet. So we need to decide what we want to provide. We need to show that it's a good idea, both from an economic and a patient point of view. We need to decide who's going to pay for all the other stuff apart from the testing. It's all very well for Genomics England to do the testing. There's an awful lot more to this than just the cost of the test. We need UK guidelines and drug labels that will tell people what to do with the results. Ideally, we'd like some kind of tied up, joined up e-prescribing service and linked records, and we need to educate people. But this is why it's going to happen. Sorry about the Daily Mail, I apologise to those of you who didn't need to see that this morning. But patients are being told that personalised medicine is a great idea and that it's going to change their lives. So they are going to come looking for it. And when you say to a patient, we can do a genetic test that decides, which drugs are safe for you to have, they almost universally think it's a great idea because they haven't thought about all the other stuff. And that's it. I hope I haven't terrified you too much, but I really think it's important to think about, because honestly, nobody else is thinking about it. So if you guys aren't and we're not, we're going to be in trouble.